plenty of evidence between the intersections of NCDs and COVID. What we're seeing around the world is that both reinforce one another and disproportionately impact on the most vulnerable communities in every country. And there are both kind of direct links between NCDs and COVID, as well as indirect links. Direct links are because NCDs are being shown to be one of the major risk factors of patients with COVID-19, increasing susceptibility to the virus, as well as the likelihood of worse outcomes, including hospitalization, complications, and fatality. I think in the early stages of the pandemic, many political leaders were very much talking about vulnerability of people with underlying medical conditions. And what we've seen is that those underlying medical conditions are very much the NCD agenda. It's people with hypertension, diabetes, obesity, etc. But in terms of the indirect links, COVID is having an indirect impact on people living with NCDs through significant disruptions of health services. We all know that COVID has placed, unparalleled strains on health systems around the world, both high income and low middle income countries alike. And we're seeing widespread disruptions to access to essential medicines for people living with NCDs, as well as blocking routine health services such as screening, treatment, and palliative care. And what this is all resulting in is a very worrying trend in delays in diagnosis, resulting in more advanced disease stages, as well as delayed, incomplete, or interrupted treatment and care for people living with NCDs. So those are a few kind of scene setting kind of context of what we're talking about in terms of the links between NCDs and COVID. And with that context in mind, what we're seeking to cover today in the webinar is to look at these links in more detail, to really try and understand the gaps that COVID has uncovered from an NCD perspective, particularly in terms of health systems and service delivery, and to really try and tease out more about what are the lessons learned that are coming out of this pandemic, because even though obviously that scene I was setting is obviously very bleak, as with many crises, there are always opportunities for building back better. And that's what many governments and the international community are really focusing on now in terms of what can we and how can we strengthen the response going forward. So with that context and with those objectives in mind, I'm now delighted to introduce our three speakers, who will each be presenting for around 10 minutes. And then at the end, we'll have time for questions and answers from the audience. And I'd encourage you all to be posting your questions into the chat facility in the Zoom webinar. So I'll introduce each speaker just before they present. So our first speaker, and I should say that all of our presentations, we're going to be hearing experiences from India, from Thailand, and from South Africa today. Our first speaker, I'm delighted to introduce Dr. Ramya Ananthakrishnan, who is the Executive Director at REACH, a civil society organisation. Dr. Ramya has worked in the field of TB control for the last 18 years in Chennai, South India. By training, she's a medical doctor with a postgraduate master's degree in community medicine. And for the last 14 years has been particularly in the field and the interlinkages between TB and NCDs. And Dr. Ramya today will be speaking about community-based TB and co-screening programs that REACH has developed. Let me pass over to you, Dr. Ramya, for your presentation. Thank you.
Thank you, Katie, and I'd like to thank the organizers for giving an opportunity to us to present on the impact of COVID on the continuum of care, lessons from Chennai, a city based in south of India. Next slide, please. I also would like to thank our partners, Lilly Global Health and AA&G, who have been supporting us in this project. So as an organization, we have been working in the space of TB care and prevention for the last 21 years. and have started stepping into the NCD area in the last 3 to 4 years. Our core activities is partnering with the private sector, and we have also forayed into areas such as advocating for TB among different stakeholders who are previously unengaged in the TB program, like the elected representatives, corporate hospitals, etc. Our main mandate and vision of the organization is providing holistic care and support. And I think that is very much pertinent in the context of today's webinar, where we are talking about not only impact, but also looking at how do we provide holistic care and support to people with NCD during these times. Our other areas of work include empowering survivors and making them TB champions so that they serve as a voice of the community. We've also been working very closely with communities and engaging them in different aspects. And last but not the least, we've also been working consistently with the media. We currently engage the media for improving and increasing reporting on non-communicable diseases. We have focused different non-communicable diseases like the chronic respiratory diseases, mental health, and this year we are focusing on cardiovascular diseases. Next slide, please. So the next set of slides, I'm going to be presenting to you from the work that we actually do, providing care and support to people with NCD and TB in the city of Chennai. As I mentioned, the city of Chennai has about 8.6 million population and is a coastal city in south of India. There is a huge and varied private sector in the city, as is the case in any urban setting in the country. And there is a multitude of practitioners. There's a multitude of private sector players like hospitals, polyclinics, pharmacies, laboratories, etc. And I think in the context of NCD and TB, as I mentioned, since we initially started our work with TB and have very recently forayed into NCD, we all know that diabetes triples the risk of developing TB, and an estimated 20% of the Indians suffer from diabetes, and diabetes is more prevalent in South India. But what was very important and interesting for us is that studies in our own setting suggested that around 50% of people with TB actually have diabetes or impaired glucose tolerance. And so that was a very, very important comorbidity that needed to be addressed while we were addressing the problem of TB. Next slide. So as I mentioned, this is the landscape of service providers for diabetes and hypertension in Chennai. So you have the public health program, which has hospitals, health centers, and primary health centers, medical colleges, while the private sector landscape involves multi-clinics, practitioners, major hospitals, pharmacists, and labs. And as all of you know, private sector is the first point of care for more than 70% of patients. And this is true not only for TB, but for any communicable and non-communicable diseases. And so this is one of the reasons why we felt that as a program, it's very, very important that when we talk about the impact, when we talk about any public health challenge, it could be TB or it could be diabetes, it's very, very important that we also engage the private sector and get them to participate in these huge public health programs. And that has been the primary mandate of REACH, where we have worked with the private sector and found mechanisms and ways of engaging them in the program. Next slide, please. So a very brief slide on the COVID situation in the state of Tamilnadu. As you can see, we started having the COVID cases from April, and we had a steep, and currently the number of cases are coming down. We touched a very high during the months of July, April, May, June. It was quite low, but that was the time when there was a complete lockdown. And then subsequently from June, July, August, you see there's been a huge number of COVID cases. And some interesting data which came in the reports actually suggested that The report actually looked at the data of the COVID deaths in the state of Tamilnadu. Both diabetes and hypertension contributed to 33% of the COVID deaths. Diabetes alone contributed to 24% of COVID deaths, and hypertension caused 13% of all COVID deaths. And 60 plus age group, if they had both hypertension and diabetes, the risk was nearly 33%. So these were some important and very staggering numbers when we looked at the comorbidities and the COVID deaths in the state. Next slide, please. So I'd just like to talk very briefly on how we engage with the private sector and talk to you about how the COVID had impacted this provision of care, especially for NCD and also TB. As I mentioned, we have been engaging private sector through these Nakshatra centers, which are centers in the private hospitals, roughly 1 per 250,000 population. And we, as part of our private sector engagement, engage with the different providers along a private health sector landscape, which means it includes practitioners, hospitals, laboratories, and chemists. And we have been providing the continuum of care to patients and their family. And this is our model for engaging the private sector for TB program. And we pretty much use the same cascade and the same model for NCD care and support. A very brief snapshot about the Nakshatra centers. Nakshatra means star, and these are centers which are provided by the private hospitals. And there is a health worker, a community health worker called Nanban, which means friend. And in this Nakshatra center, there is access to free X-ray, free gene expert testing, and treatment initiation and treatment adherence support and notification. Now, through the NCD care, we've also been providing access to the diabetes and hypertension screening, which I'll be talking about in a little while. And when we talk about adherence and support, we provide risk assessment for the patient as a whole. We provide individual and family counseling and contact screening, and additional nutrition support and follow-up, ensuring that the patients actually complete their treatment successfully. Next slide, please. So in the private sector, we create a network for care, which includes the Nakshatra Center at the center and the all other private players in the spokes. And this is the center which is a closely coordinated network. And this is more of a private partnership that we have built and are currently working with. As you can see, these Nakshatra centers are spread across the city of Chennai. Next slide. So we focus on providing this continuum of care and support to people with TB and NCD. What we have observed is that once patients come with symptoms and they get diagnosed, it's very, very important that they receive care and support at every step till initiation of treatment. And I think equal emphasis is needed on ensuring that they actually adhere to treatment. So that has been pretty much the lesson that we've learned both for TB and NCD care. Next slide. So this is our model of engagement with the private sector, where we reach out to private practitioners. We sensitize them on the standard guidelines for NCD, and we provide the services through the Nakshatra Center. So we sensitize them on what services are available in the Nakshatra Centers, and we provide support for diagnostic and treatment services through these Nakshatra Centers. And for the case of TB, we also help in the notification and help support the follow-up of patients with NCD, diabetes and hypertension. And we have different menu of options for the private practitioners. So we encourage them that they could either refer them to the nearest centers if the patient is not able to afford the diagnosis or treatment, or they could refer them to the nearest Nakshatra centers or they could access the Nakshatra centers, but the consultation is with the patient, with the private practitioner, or they could actually treat by themselves. Next slide. So this is basically the search, treat, prevent that we traditionally follow in the TB, which is very much superimposed for the NCD care also, where we, for the search, we help screen for TB, diabetes mellitus, we help in the diagnosis and also in the notification. A treatment, we provide access to anti-TB drugs and link patients to diabetes and hypertension care and provide counseling. And we also focus on increasing the awareness of the community and advocate with the program for better testing and access. Next slide. So the strategies for diabetes hypertension screening that we offer through the Nakshatra centers, where we screen for all people with symptoms of TB. We also provide free screening vouchers for the household contacts of patients with TB. And they could also avail the screening at a network of accredited private laboratories. Similarly, for hypertension, they can screen at the Nakshatra centers, where we have digital BP apparatus and the TB Nandans screen the patients. And there is also free screening for household contact at the clinics and Nakshatra centers. Next slide, please. So just to give you the landscape of private sector that we work with, as you see from the denominator of 10,000, we work with about 3,000 private practitioners, and most of them are general physicians, pediatricians, pure diabetologists, etc. Next slide. So very briefly looking at what has been the care in the last 9 months. We were able to provide access to diagnosis for nearly 4,500 people with TB, and we were able to provide free chest X-ray and gene expert, and 1,756 were diagnosed with TB, and most of them initiated on treatment. When we come to diabetes and hypertension, among the 5,355 people eligible based on age 30 years and above, in diabetes, we screened nearly 2,000, and we were actually able to identify 942 people with diabetes, and about 80% of them were linked to care. In hypertension, it was a small, because we started that intervention very recently. We were able to screen 1,286, and 186 people with hypertension were identified, and most of them were linked to care. Next slide, please. So these are some of the communication materials which we've also developed and disseminated. And during the COVID, as you all know, since the patients were counseled, and we reached out to the practitioners over phone. So we sent most of these messages by WhatsApp, and called and spoke to them. So these are the different materials that were disseminated during these times. Next slide. So this is just to give you the impact that it had, because this is our denominator, because the entire initiative was focusing on how we could use TB as an entry point for screening for diabetes and hypertension. So our denominator pretty much dependent on the number of people who came with symptoms of TB. And as you can see, this trend gives you the numbers in the last 4 years. As we scaled up the private sector engagement between 16 to 17, the number of referrals and the number of patients that we diagnosed steadily increased. But if you look at the Q2 of 2020, you could see a very sharp decrease. And then subsequently, there is again a slight increase in Q3. One of the things which is also very interesting is that if you look at the numbers, we find that more patients were found in Q3 in terms of the positivity. And this probably is because patients seek care much later and they come with very advanced disease. And that's probably the reason why there is an increased positivity. Next slide, please. So in terms of what has been the impact of COVID on private practice, as you can see in April and May, among the 40 centers, only one was fully functioning. And as you can see, the rest were either offering only limited services or only offering emergency services. And in June also, the situation was pretty much the same with a very slight improvement. And we did a dipstick analysis of what is the practice of the private practitioners in June 2020. And we found that about 1/3 of them were closed and another 7% was only open for emergency services, and 60% were open. And even the 60% that were open mostly had restricted timing for seeing patients, which actually put a lot of the patients into difficulties, and also teleconsultations was only practiced in some of these clinics. So the impact was huge in terms of patients who wanted to come for follow-up. 44% of the high referring PPs were engaged in COVID duty. 62% of the PPs were actually practicing with restricted timings. Now, this is the current status. In fact, 5 of our high referring PPs died due to COVID. It was very unfortunate. And 5% of the PPs were providing on video consultation. Next slide, please. So when we looked at the blood sugar levels using RBS among those screened, and this is we did as part of our screening, as you can see among the people with symptoms of TB and contact, the blood sugar levels, if you look at, let's say, 200 plus, about 20% of all those, of all those who were tested had nearly 200 plus blood sugar. And the slide on the chart on the right side actually shows what is the status among those with known diabetes. And that was really very shocking because close to 85% of all with known diabetes actually had a blood sugar level of more than 200 plus. So this was really a very, very shocking result that we observed. Next slide, please. When you look at hypertension, also when we looked at the blood pressure levels also, as you can see, the blood pressure based on the systolic and diastolic, which was quite high among people with known hypertension, was very, very high. So, and I think the reasons when we interacted with the patients was that though patients continued getting medicines from the pharmacies, they could not go back to the doctors for consultation. So that was a huge problem. And so they were not able to monitor their blood sugar or their blood pressure. And so that was one of the major reasons for this. Second was because of the economic inactivity, they were not able to procure medicines. So these were some of the major challenges which was responsible probably for this findings that we see here. Next slide. So as I mentioned, the challenges faced by the patients was because of stigma related to COVID and isolation. They didn't come forward for any screening or testing, and so the OP strength, outpatient strength dropped drastically. They had difficulties in accessing private practitioners, and still there is a preference to meet private practitioner in person, and people are not comfortable with online consultation. Restricted transport facilities, and many patients also go back to their native places. So that's been a huge challenge. And because of the economic disruption, there has been difficulties in the purchasing patterns, in accessing the treatment adherence, the HbA1c screening, etc. So what we have done in terms of support is we've helped in sputum collection transport. We've provided access to screening and diagnostic tests for diabetes, both at the Nakshatra centers and in the private laboratories. Counseling has been primarily in person when they come to the center, and also through telephone. And we've been able to provide regular uninterrupted supply of 80 anti-TB drugs And we've also facilitated direct benefit transfer of the program, which is about close to about $10 per month for all the patients, which is provided by the Government of India. And where needed, additional nutrition support is also provided. Next slide. It's my last slide. In terms of how are we sustaining the PP engagement, we've been doing in-person follow-up visits, encouraging them and talking to them about the services available that they could actually refer patients for the blood sugar testing in the Nakshatra centers. We've also are doing mobile-based communication and follow-up and using mobile messaging. And our health workers also, we've been building the capacity, training them on the COVID precautions. We've made changes to their workflow. All of them are now trained in a electronic real-time data entry system, and virtual capacity building sessions and review meetings take place. Next slide, please. So as you can see, a virtual training of our TB non-bins, and it's very, very heartening for us because I think Dr. Salman has seen the team, and these are very committed health workers, and so it's been such an empowering experience for all of them because now they are as comfortable as us using platforms like Zoom and all the other platforms, and they are able to communicate not only with us but also with the patients and with the private practitioners. So as you can see, recently the World Diabetes Day also was observed, and we all participated along with the private sector. Next slide, please. So I'd like to end this presentation by saying that I think what we started as an organization, we've always looked at holistic care and support. And that was one of the reasons why we got into the NCD space, because we didn't want to be disease specific. And one patient with multiple diseases, and there are multiple people looking at that person. So we felt that it's important as part of holistic care and support. It's important to look at all the diseases that the patient has. And I think in the context of COVID, it's going to be very important that we also need to address that, their challenges. And so in terms of, again, the impact on the NCD, I think the adherence especially has really taken a toll as we saw in terms of the numbers. And last is, I think it's also important that we need to look at new ways of reaching out, not only to patients, but to practitioners. And it's important to engage the private sector, as it's just not enough if public sector alone rolls out program for COVID and for mitigating the effects of COVID. It's equally important to engage private sector and find ways and means of doing it. So this, on behalf of the team, I made this presentation. So this is our team from Chennai. Thank you so much for this opportunity.
Thanks so much, Dr. Ramya, for sharing those really interesting those really interesting experiences and insights. I think it's a really important model in terms of actually how we're delivering kind of holistic care and support to multiple diseases, as you said, during the COVID pandemic, which is really highlighting the need for kind of, a more holistic approach to health and health systems, really. So thank you so much, and no doubt we'll come back with questions at the end of all of the presentations. So let's move straight on to our second presenter. And just as a reminder to all participants, please do obviously ask your questions in the Q&A chat facility, and we'll come back to them at the end of all presentations. So our next speaker is Dr. Pat Rajatanavin, who is a research fellow at the International Health Policy Programme in Bangkok, Thailand. Dr. Pat is a medical doctor by training, and he's had an interest in health systems for a long time. He, for 3 years, worked in rural parts of Thailand on the Thai-Cambodia border, working at every level of hospital, from regional hospital to small district hospitals, experiencing the Thai health system in rural area settings. And his research area particularly is focused on health systems and NCDs. And Dr. Pat will be speaking to us today about maintaining care for NCDs through COVID-19 within the Thai context. So over to you, Dr. Pat. Thank you.
Okay, thank you, Katie. Thank you everyone for joining this webinar. Okay, let's start with some background of Thailand. Thailand is quite a big country with almost 70 million population. We are upper middle income country with good health status. Life expectancy is at 77. 70% of health resources is in public sector. Current health expenditure is at 3.7% of GDP with low out-of-pocket at 11%. We achieved universal health coverage in 2002 through 3 insurance schemes. All have comprehensive benefit packages. Thailand has a strong public health infrastructure, starting from primary care. We have 1 million health volunteers in every village, 10,000 health centers in every sub-district, and almost 1,000 hospitals. Because of strong infrastructure, public sector take care most of health services in country. First, I will show you how NCD care has been organized before COVID-19. In Thailand, NCD care system is totally facility-based service. The site of patient treatment is based on their status. Uncontrolled and partially controlled are treated at hospital, while controlled patients treated at health center. Patient can be referred up, back, and through hospital health center depend on their status. Additionally, every year, patient will need to go to hospital for complication screening. Then came the COVID-19. On 13 January this year, Thailand report first confirmed COVID case outside China. COVID situation in Thailand can be divided in 3 phases. Phase 1, the beginning of outbreak. The health system still provided normal services, but with added COVID prevention. Phase 2, peak of the outbreak. Thailand redesigned service delivery to maintain care for every patient. Phase 3, outbreak subsided. Thailand resumed normal services, also sustaining our new service delivery developed during the outbreak. This is COVID statistic as of today. Thailand has only 3,900 cases since the beginning of the year. At phase 1, COVID situation in Thailand was under control. Most were imported cases with only some local transmission. Hospitals continue to provide normal service while set up infectious prevention. COVID-19 symptom screening was set up at the point of entry, setting up acute respiratory infection clinic outside the main building. And also we ensure that everyone, both healthcare worker and patient, has good personal protection. On the left is a COVID symptom screening at the point of entry. Everyone will be asked screening question and walk through thermal scan before enter hospital. On the right is a picture of the newly set up ARI outside the main building. Then came phase 2, peak of the outbreak. Thailand was under lockdown and curfew. Hospital deferred all non-urgent health services to reduce crowding while still open for essential services. To ensure hospital operation throughout the pandemic, Thailand has strengthened their infectious control measures, now including strict social distancing in hospital. Hospital care was still provided for unstable chronic cases, but for stable cases, the care will be provided at home. This was done to reduce traveling of NCD patients to hospital. Stable patients will receive drugs at home, delivered by postal or village health volunteers. Prescription cover longer period to reduce visits. In some cases, communication between patient and hospital was offered through telemedicine. Moreover, a door knock operation by village health volunteer, which an intention to screen people with COVID risk who have come back to hometown after the lockdown, also help identify some NCD patients. In hospital, on the left, you see that pharmacists dispense drugs through sliders to have a social distancing, and the healthcare worker work behind plastic barrier. and the ban of shoulder-to-shoulder sitting in hospital. In this picture, you see doctors were seeing patients through telemedicine and dispensing their drugs through postal delivery. These are the village health volunteer work. On the left, village health volunteers delivered drugs to patient home by their own motorcycle. And right is the cover of Operation Door Knock Manual written in Thai. However, hospital alone is not enough. Other sectors need to play a role too. First, on regulation, telemedicine has not fully settled before the COVID. However, every stakeholder agreed that telemedicine could be done as an emergency necessity. Then, Thai FDA waived the law that prohibited delivery of special controlled drugs through postal delivery. Also, health insurance lifted off gatekeeping regulation that patients must receive service only at registered health facility to increase accessibility during lockdown. For financial, insurance schemes subsidize new services like drug delivery and telemedicine without hesitancy. Moreover, hazard fee was paid by the government to the frontline workers. Drug supply is another key factor in NCD care. Ministry of Public Health brought our stakeholders to discuss on matching of domestic supply and demand during the outbreak time. Also, due to international travel ban, manufacturers sought for alternative suppliers to continue production. Moreover, customs waived the duty and regulation on important drugs to reduce delay and price. For IT, the government gives free internet and increased internet speed for all. Furthermore, fund was given to hospitals to upgrade their IT system. All this helped people access to telemedicine and information. Then the third phase, when the COVID subsides. At this time, Thailand has fewer than 10 cases per day, mostly imported cases. Hospitals have resumed their normal service, but infectious control are still in place. Also, we use this opportunity to pilot new model of NCD care called Pattani model, which is the name of the southern province of Thailand where the model implemented. This is a picture of NCD care model before the COVID. What has changed is that in Pattani model, we have telemedicine and drug delivery option for patients, serving directly to the community. Moreover, for NCDs like hypertension and diabetes, patients who use telemedicine will need to report their blood pressure or sugar through internet first, which can be measured at community checkup point if they don't own the equipment. All of these are made possible by implementation of new IT system, which also serve as monitoring and evaluation of the system too. In conclusion, first, prompt and full response to COVID-19 and NCD care are key to Thailand's success. We control outbreak quickly and never forget about maintaining other essential care. Second, application of available technology and infrastructure such as telemedicine, postal delivery, and village health volunteers play an important role and accelerated our response significantly. Third, support from multiple agencies were crucial. Otherwise, many interventions would be blocked by regulation or lack of funding. Fourth, it should be reminded that this success is only a short-term solution. We succeed in continuing NCD care during the outbreak, but whether patients receive good quality of care is still a question. Lastly, I would like to say that even though COVID-19 has brought devastating effect on health, economy, and society, it also accelerated remodeling of NCD care into the digital era too. Thank you.
Thank you very much, Dr. Pat, for that presentation and for sharing the experience of Thailand and a very effective response to COVID to ensure continuation of NCD care. So as I say, we'll come back to questions at the end. So now let's go to our final speaker, who is Professor Monique Marks. Professor Marks is the head of the Urban Futures Centre at the Durban University of Technology. Initially trained as a social worker, Professor Marks holds a doctorate in sociology from the University of Natal. Over the past 5 years, she's developed a special interest in drug use disorders and drug policy, and together with the team established South Africa's first opioid substitution demonstration programme in Durban, which has been fundamental in shaping government policy and implementation related to drug use and drug use disorders. Professor Marks is going to be speaking to us today about maintaining care to key vulnerable groups during the COVID-19 pandemic. So over to you, Professor Marks.
Hi, everybody. Let me just share the screen. Has that worked? Is that fine? Can people see it?
Yeah.
Okay, great. Okay, so I just wanted to begin. Thanks very much for the introduction and for the two fascinating talks by my co-speakers. And of course, for the creation of this webinar, which I think is a brilliant idea, and I'm very privileged to be part of it. So I'm going to speak about something which may not seem, sorry, I'm just seeing why I can't get into this. Sorry. The thing has disrupted the transmission thing. Oh no. Okay, I'm going to have to just do it manually. Okay, so I'm going to be talking about how homeless people managed to access, probably for the first time, treatment for drug use disorders during COVID at the height of our lockdown. And I wanted to give a bit of a context to this first before I begin, and then explain what we did. It's in the light of talking about the difficulties or the disruption that took place in relation to all services, both to communicable and non-communicable illnesses during COVID, and how this is maybe a different kind of a story. As Pat was saying, you know, COVID did in some ways catalyze a different response. I also wanted to say that before I begin, I'm talking about drug use disorders, which not everybody sees necessarily as a non-communicable disease. And I think it is controversial to talk about drug use disorders as a medical issue. But for the purposes of this talk, I'm going to accept that it is a form of a relapsing, remitting brain illness, which is dealt with or can be dealt with medically, and for us much more preferable to be dealt with medically than to be dealt with as a law enforcement problem or something which is a social disruptor. So the picture that you can see in front of you was really, it represents one of the shelters that was established by the municipality for homeless people at the very beginning of lockdown. This particular photo is taken at one of the lockdown facilities, which was an underground parking lot at a sports ground where 260 people were housed throughout lockdown. And I can talk more about that later on. But let me get into the meat of this. The state of harm reduction prior to COVID is important because it then gives you a measure of how important COVID was in terms of what I've called the light shines through the cracks. So prior to lockdown, we had no opiate substitution therapy programs at all in the country. We had one in Durban in 2017 to 2019, which was a demonstration program. That was exactly that, a demonstration program to show quality of life changes. At the end of 2019, that then concluded. So in the entire of Durban, there was no access to opiate substitution therapy, despite the radical increase in opiate use disorders in Durban and throughout the country. In addition to that, what had happened 2.5 years prior to COVID lockdown was the closure of the one needle syringe program. And when I say one, it was organized by a civil society grouping, an NGO, that was closed. And that meant that many people who were injectors were not able to access clean needles and syringes, with obviously a huge onward transmission of HIV and hepatitis. Law enforcement was seen as the first and the last responders to people who use drugs. And of course, prison was seen as the place of care, if you want to call it that, rather than any form of medical treatment or any form of evidence-based treatment as recommended by, for example, the World Health Organization. Generally, what we had in South Africa, and this is not only the case in relation to drug use disorders, is a very strong political conservatism. And what that meant in terms of dealing with drug use disorders is a push for abstinence and for prohibition. And along with that push for abstinence and prohibition was ongoing reports of human rights abuses, mostly by the police towards people who use drugs, and particularly those from low income and homeless backgrounds. And then COVID emerged. And what happened is that it mobilized what I've called here activist city officials, people from within the city. And when I talk about in the city, I'm talking about people who work in the municipality itself as a state body, who realized that, that something more radical had to be done, and that we had to take care of vulnerable population groupings. And as a result, what happened is that we had a deputy mayor who decided to operationalize a network of both state and non-state actors to respond in a very radical and humane way to people that were homeless. Now, what that meant, of course, is an easing of the bureaucratic inertia that we generally find when we work with government agencies, and a sudden look towards evidence-based interventions as a way of dealing with drug use during COVID. Now, not all of this is a kind of because people are nice. There were also very logical reasons for this. The city did not want homeless people to be vectors of COVID, either from the general population or to the homeless community itself. So some of it was human rights based, but not all of it. So what happened then is, with the recognition that about, in some places, between 40 and 60% of the homeless population do have a substance use disorder, it was then decided that we would provide medical services, evidence-based medical services to people who use drugs in the homeless facilities. There were 9 of these in Durban, and we identified 2 to be able to provide services to people who were going through moderate to very severe withdrawals. So what we were doing here is we were meeting the needs of people where they were at, which is very much in line with a harm reduction approach rather than in line with a prohibitionist approach. The aim was also to reduce anxiety in a very stressful situation. And that's not just about the anxiety of homeless people about what their situation was, but also around the general population, who actually became very concerned about what was going to happen to homeless people in withdrawal during COVID. Of course, the anxiety was partly linked to a rise in crime, but there was actually probably for the first time a real concern about the rights of individuals who were homeless, the rights of a very vulnerable population grouping. And so what the focus during COVID was, of course, it was to deal with COVID as a pandemic, but it was also about, in regards to the homeless population, a concern with general wellness rather than just with health. So what did we do in the homeless shelters? And I've shown you here, this was just so that people know. This is where people were sleeping on mattresses that were donated. And I can talk about the funding of this later during questions. And this is the psychiatrist, the specialist psychiatrist who volunteered with us for a period of 12 weeks in this lockdown facility and one other one. And here he is actually going to someone in need of care rather than him having to come to where the program was running from. So what did this withdrawal management program look like? Sorry, oh my gosh, the battery is low. So what happened, of course, as I've said already, is that a medical approach was prioritized over a law enforcement approach. And I've already spoken about the recognition that if this wasn't dealt with, it actually could have compromised the intention of lockdown. In other words, if homeless people were looking for drugs, they would then actually be breaking lockdown regulations with very severe implications for COVID, the COVID pandemic. What we did then is we put together, and I say we because it really wasn't just DUT, it was done very closely with an organization called Advanced Access and Delivery, who are part of this presentation. I see it that way, and who are very much part of all the work that I do, and are part of the group that actually put together this webinar. But we put together a private medical team because at the time at which this was done, government still had not accepted that opiate substitution therapy was an acceptable way of dealing with an opioid use disorder. And so a private medical team operated on a public facility. Now, this in itself was very significant because it was an acknowledgement by the city and by the government that this was necessary. What we did is we assessed people in terms of what their state of withdrawal was, whether they were in mild, moderate, or severe. We dealt with people in mild withdrawals differently, and we can talk about that as well in questions. But for people that were in moderate and severe withdrawal, we provided an opiate substitute. In this case, we used methadone because it was much easier to dispense, and also because some of us had a history of working with methadone previously, and also because of its very long history of use across the world. And we provided then for 260 people in lockdown safe spaces, in 2 of them, a short-term OST program using methadone. What this meant, and we had 3 nurses as well, and we had a number of social workers working with us, some on a voluntary basis, some paid by the city, is that we had a daily observed dosing of methadone. We had a ceiling amount that we could give people in terms of the funding that we had available. But because the majority of people that we were treating were smokers rather than injectors, the dose was adequate in terms of dealing with withdrawal and allowing people to cope for the 3 months that they were in treatment. And the psychosocial services were voluntary, in line with a very low threshold approach to providing opiate substitution therapy. Okay, sorry, this battery is running low, I'm not sure why. Okay, so I wanted to just quickly play 2 quick videos for you. They're very, very quick, just so that you can understand why we saw lockdown as an opportunity rather than as a threat necessarily. This is one of the people who was on our program.
My name is Katie Dain. So I wanted to say thanks to this program. It's been the greatest thing in our lives. It's more like a blessing. We earn so much. In other side, Corona is a disease and a case in other side, but in other side, I feel like it's a blessing because we gain so much with it. And now our life has changed. Now going back to what we started, because we started it without.
I think her computer did die, Katie, by the looks of it.
Yeah, I think we've just lost Dr. Marks. Hopefully she'll be able to rejoin. But perhaps in the interim, we'll start going through some of the questions, and hopefully we'll have Dr. Marks kind of join us again. So thank you all, obviously, for sharing such interesting presentations. I'd invite all of the panelists to be turning on your videos as we're going to have some Q&A now. And oh, I think we've got Monique back. Let's see.
Sorry, it's me again.
Hi, Professor Marks. Yep. Do you want to carry on?
No,
yep.
we had a cut in our electricity, so I got cut off from that. So I've had to transfer onto the telephone. I'm really sorry about that. But we're trying to work now with the generator. It's a very South African thing. Okay, so I was showing you that because it was one of the recipients of the OST program that was basically saying what COVID was an opportunity for a number of people, in this case 260 people, to deal with their, to normalize their lives in some form or other. And I've also got a video which I'm hoping now will come up just in a few minutes when I'm off my phone and back onto the computer. We also had a number of professionals who we were working with who spoke about how significant this was in terms of them learning about how to deal with substance use disorders in ways that is completely different from how they had been taught as professional nurses or social workers. So I'm going to try and conclude without any access to PowerPoint, and I'm very sorry about that. But I think sorry, I don't know what's going on. Sorry, somebody's trying to fix it up so that I can conclude in relation to what it was. But I'll conclude without that if I have to. So what we had, I think, in Durban, and myself and a colleague who is part of this audience, Michael Wilson from Advanced Access and Delivery, have really written about how COVID actually was what we've called a Durban moment. And why we called it a Durban moment is because really it was a moment where Durban could shine through and show that for the first time, actually, the city was prepared and willing to bring together a range of actors across the state and non-state to care for a very vulnerable population group and to provide services that otherwise would not have been provided. So I wanted to just to then very quickly turn to where are we now, because we are no longer in a serious lockdown situation. The lockdown facilities have been closed now for about 2 months, and we are now in level 1 as opposed to level 5, which was the case when we started the OST program. What has happened is that the city has actually given us, and us, I mean those of us that are implementers, a facility, a building, I'll be 1 second, where we are now able to provide harm reduction services, mostly to homeless people, but also to low-income people. And there's a range of services which we are currently providing. The first is obviously an ongoing provision of opiate substitution therapy. And now it's no longer just dealing with withdrawals, but it's more of a maintenance program as well. We also provide clean needles and syringes because, interestingly, it was during lockdown level 4 that the city decided that we could reinstate our needle syringe program for obvious reasons. And the obvious reason was that they didn't want an increase in cases of hepatitis and of HIV in the midst of a pandemic. So strangely, it was during COVID that our needle syringe program was reinstated. And just to end off, we are hoping to also introduce what we're calling an overdose prevention space or a drug consumption room at our harm reduction center, which is called Belhaven Harm Reduction Center, which will be the first of its kind on the continent. So in conclusion then, I think in relation to drug use disorders and perhaps to other illnesses, although I'm less convinced about other illnesses in Durban and South Africa generally, non-communicable illnesses, but certainly in relation to drug use disorders, COVID has been a light that has shone through the cracks. I should also add that people who are accessing and who have been accessing these services during lockdown and beyond have also been tested and screened and referred for TB, hepatitis, and HIV. So a lot of positive outcomes from a very difficult and traumatic initial pandemic beginning. So thanks very much. I'm really sorry for the break. I'm happy I am back on the computer now, but I will move from my phone back to the computer. Thank you for tolerating that disruption, but we're all learning to live with disruption. So that's it, and I'll answer any questions that come up.
Thanks so much, Professor Marks, for that really interesting presentation and your expert ability to be able to finish and summarize without anything in front of you. So I think we've now heard from all of our speakers. We've heard from a range of different perspectives and countries, obviously, from Chennai in terms of delivering the integrated and comprehensive TB and NCD care during times of COVID and the adaptations that had to happen there, to the context of Thailand and the continuation of NCD care and the changes that had to be implemented in order to ensure that. And then we've heard quite a different perspective from Durban in terms of the opportunity that COVID has actually provided in elevating the issue of homelessness and shifting policy approaches to harm reduction, which is a really interesting case study. It's also opportunity for NCDs, for mental health, for homelessness, and for drug disorders, very real and in a very real way. So I guess my first question if I could invite all of our panelists to show your videos, because we're going to have a few minutes here for questions and answers if participants can stick with us. I realize we're slightly over time, but so much food for thought from the presentations. So my first question to panelists is really a question around, when we're thinking about building back better from COVID and the pandemic, what do you see as the kind of main lessons and innovations that we need to ensure stick and are sustainable from an NCD perspective? Some of them have been mentioned already. I think, Pat, you mentioned telemedicine, but let me open the floor to panelists in terms of the main lessons and innovations.
Do you want us to go in order, Katie? Are you wanting us to go in order, or do you want us to speak?
Yeah, please jump in. Yeah, please go for it.
I mean, I think from our perspective, the main lesson is that, what we learned was how COVID showed us that all the bureaucratic red tape that usually goes with the provision of medical and other services by the city can really, really, be done away with. And I think it was an experimentation in how you can speed up processes and allow them to then continue without this constant referral to higher level authorities and to political decision making. And I think that that's often what we learn in states of crisis, that things can be done with much less pain and with much less bureaucracy than usually is the case. And I think the other thing that from a more sort of health provision perspective that we learned is that you can very, very quickly and in the most adverse of conditions set up a healthcare service which has absolutely detailed filing that can be done and that can then be referred later on, that you don't actually need high level technology to roll out a very quick service provision, which can later then be linked to high technologies or vice versa. So I think what Pat was saying is absolutely true, that this has kicked in a high digital technology response, but it's also kicked in again, a return to doing things in a way that is very manual and very effective, and that also shouldn't be frowned upon. So we have here two very different technologies operating in the same space.
Thanks so much, Monique. Let me ask the same question to Dr. Ramya.
Thanks, Katie. I think what we learned is that it's important to invest in education, especially patient education, because I think we found in COVID, that once people understood what the challenges and what are the precautions that needs to be taken, many of them followed it. I mean, simple things like cough hygiene, right? And I mean, for someone working in TB, where we worked for so many years, where we talked about infection control and we talk about safe cough practices. So it wasn't followed. So I think it's today the people are more tuned to these public health emergencies, and I think we should strike when the iron is hot and use this opportunity to talk about not only COVID, but all the other important public health challenges, and in a way which can be easily said, which is easily conveyed to all the people. So I think it's a huge potential there.
And Dr. Pat, how about from your perspective in Thailand? Key innovations. I mean, you obviously mentioned telemedicine and community health workers in your presentation.
Okay, I think that's what the direction we are going about to the telemedicine. But what we still need now is the self-care. The patients still have to need some of their own blood pressure or their own glucose monitoring, something like that, because only telemedicine and mobile cannot, we cannot check for their symptom or their progress on the control of disease. That's what we're gonna need next, and to deliver care outside the hospital, and also to sustain this telemedicine, because most of the people still have mindset that would like to go to the hospital, but we have to make the telemedicine into the maybe a very good alternative for them, such as a shorter time, and the quality is on par or even better. And we have to see that, because most of the patient right now that is not diagnosed with NCD is the younger generation, and they are very keen with the technology. I think this may be the model that will suit this generation, younger generation, that we can prevent them to get a complication in the future.
Thank you, Dr. Pat.
Thank you.
We've got a question that's come through the chat, which is quite relevant and links nicely to the conversations around telemedicine, which is, do we need special associations with telecommunication firms in healthcare so that we're able to reach the last mile, often where network and connectivity is poor? Who would like to take that one?
I can maybe do that again. Sorry, Katie, if you want me to kick off, I can.
Sure.
I mean, I think, you know, in as much as what I've said is that we can do things without being high tech, you know, I mean, I think it's an important takeaway, because we're often working in situations where we don't have high tech. But I think what those of us who've been working in this harm reduction space are now trying to do, and this is about sustainability really going forward, is recognizing that we need to actually be bringing in the private sector, not just the private health sector, but private business, as seeing this as a point of, I suppose, investment in the space in which they operate, and that healthcare is definitely a place where all private sector people should be investing in. Now, you know, tech is a key space for people to come in and to link up people who otherwise would be disconnected in ways that will allow them to reach out for whatever it may be, to connect with significant people in their lives, which will allow for life normalization, to connect to ideas that are happening in the labor force, to connect to healthcare services, to connect to possibilities for housing or whatever else they may want to do. So I think for me, what's come out of the other two presentations, which I think is really, really important, is the nexus between, you know, public, private, and non-government. And I think it's the private sector that needs to really be stepping in much, much bigger than they have been up until now, and saying healthcare concerns all of us. And if we don't provide what's needed, and this is technology based, then we're really going to lose the wins that we gained over COVID if we prepare to accept that there were wins.
If I can come in, Katie?
Please.
Yeah. In response to this question, I think what we found here in India is that it's it is not important to have these very fancy technologies and partnerships. And I think ultimately at the end of the day, it just translates to that connect, that human connect, and that could be done just using a regular telephone. And I think it's important to follow it up with the actual service delivery, which is providing the access to diagnosis and access to treatment. And using simple telephone, as long as we could do this coordination. And so what it actually boils down to is this coordination between the different players, and it's a hard work. And though we do have now these fancy technologies which sends automated messages, but then what we are also seeing is that if everything is automated, the rapport is not there. And I think in healthcare, rapport is something which as health professionals, we all need to establish that linkage and with the patients, right? And to help them, to educate, to counsel them, and to encourage them. So I think we need to find this balance between technology and also getting into the space where we do any in-person kind of access. So I think that is my take on this question.
Should I? Okay.
Please do. Yeah, thank you, Dr.
Yes. I think it's important to associate with the telecommunication. So because actually in Thailand, 75% of the mobile user is still in the prepaid, not a postpaid. So that's why. So they may not have the sustainable internet connection that may depend on their income to something like that. Okay, they have a access to service like a social network because the telecommunication give a promotion to free use of the social network. And yeah, if we have a connection with them, okay, telemedicine might be like a another waiving application or about health, something that they can be used. But actually the technology is internet is like a standard infrastructure for the 21st century. I think the sector that we need to push this infrastructure coverage is the government, because it's not just the health sector that benefit from this infrastructure. It's many other sectors, especially the private sector, who benefit from this. In Thailand, we have a 3G coverage 100% because of the private that would like to use them on a commercial purpose, and the health has got a benefit from that.
Thank you. Let me ask just one final question, which very much links and builds off that previous one, which is if there's so much more focus and reliance in a way on telemedicine, are we seeing in parallel an increased investment in patient education and health literacy? Because surely that needs to happen. Otherwise, telemedicine is all very well and good, but unless you've got educated and informed patients to know how to manage their disease and their conditions, it's not going to result in good outcomes. Anyone want to take that one?
I was just filling in because I felt like maybe I should, because yeah. I mean, I think that you're absolutely right, Katie. I mean, I think that if there isn't an uptake, and it could be for a variety of reasons, then your technology is not fit for purpose. And I think that, it's probably why Ramya and I have a very similar perspective on this, because I think we are operating from spaces where people are not necessarily as digital savvy as they may be, for example, in other parts of the world, including Thailand. And so it would be very, very difficult, I think, to monitor a variety of chronic illnesses through a kind of telecommunication process when most people are not even at a basic level of adherence in terms of being retained on any form of treatment. So there's something missing here, which we really need to fill. And I think, again, I just wanted to agree with Ramya that I think that the connection between caregivers, whatever that may look like, and people that are needing care to deal with their NCDs is critical. In the case of drug use disorders, what we do know as an absolute fact is that, that connection that Ramya was speaking about is actually the only effective treatment for in this case, a drug use disorder. The medication is critical, but it's actually the connection that means a lot more in terms of well-being rather than just health. And so there's a concern there around how technology can break connection. There are ways in which it can enable it, but I think that in contexts where people don't have access to any basic technology and also, and maybe not even knowledge around how to monitor themselves or even the support systems to do that, it can become a hindrance. So I think we need to be able to negotiate this in a way that is contextually specific, and that's not in any way to go against what Pat's saying. I think what he's saying is absolutely critical, and it's what we could be aiming for. So long as people use technology in ways that are human-centered, and that doesn't disappear.
Thanks, Professor Marks. And I think with that, my moderation skills have obviously not been up to, because I realised we're over 20 over the time allotted, and I appreciate everyone stuck with us to the end. But I think we need to now wrap up. So I really want to, from my side, all of our speakers, for your fantastic presentations and really kind of concrete case studies of the response to COVID for NCDs. And let me now pass over to Dr. Srinath Reddy, President of PHFI, one of the co-organisers for the webinar, to summarise and wrap up.
Thank you very much, Katie, for steering this so elegantly. I thank all the speakers for their excellent participation. Very clear messages have emerged now from each of the three presentations, as well as the discussion that has followed. Firstly, Thailand has shown that when you have a strong, efficient, and empathetic health system functioning well in the steady state, you can actually create a surge response to competently and compassionately meet a public health emergency like COVID-19 without being swept off your feet. So that actually sends a message globally that you need to continually invest in building up strong health systems. From South Africa, from Durban, we have a very good message that when you're dealing with public health emergencies, particularly among vulnerable people who are likely to be affected, then you cannot take a law and order approach and continue to heap more indignation and discrimination upon them. And actually, your public health goals will be set back if you do that. Therefore, a public health approach or a medical approach, as the speaker called it, actually has provided a much better approach to management of this particular challenge. And therefore, South Africa, and particularly Durban, has emerged the better for it. And perhaps that will be a lesson for the future when dealing with even issues like substance abuse and protecting the rights of vulnerable people with greater care and compassion. From Tamilnadu in India, we have a clear example of how multiple players and partnerships can play a very effective role in dealing with chronic conditions, whether they're infectious like tuberculosis, which also is, in a sense, a chronic disease, or diabetes or other non-communicable diseases, and how, while these are interacting in the space of COVID, how partnerships which bring in not only governmental agencies, but also not-for-profit and for-profit private groups together can actually bring about a much better positive response. And we now recognize that non-communicable diseases and infectious diseases do not operate in separate orbits, that they are very much interlinked. In fact, not only are non-communicable diseases laying the ground for respiratory viruses like COVID and other respiratory viruses too, to play havoc and claim larger number of lives because of the increased susceptibility of people with non-communicable diseases to severe illness and possibly death. But also, these chronic conditions tend to get neglected when the NCDs go out of focus because of a public health emergency. But people must recognize that even biologically, non-communicable diseases cause inflammation in the body and actually are already damaging many tissues in the body, including the blood vessels. And the COVID virus only super adds further inflammation and therefore can easily cause devastation. So all of these factors operate together, and unless we tackle all of these through a very efficient health system and also address all the determinants of non-communicable diseases and infectious diseases together, we'll not have a successful public health approach. And that is the lesson that our speakers have given us today, and we will carry that lesson forward into our education as well as advocacy as we move along. So thank you very much for your participation. With this, we close this webinar, and I thank our partner from Harvard for having hosted this along with us, and all of the speakers who have contributed their rich experience and knowledge to this, and our audience who actually listened and sent in very stimulating questions, which have evoked very good responses, which have further enhanced the presentations. Thank you very much.